The Society for Cannabis Clinicians Medical Cannabis Conference is in Denver, Colorado this year. For 15% off at registration, use our code CP15.
Hello, everyone, and welcome to the show. This is Evidence in the Green, Closing the Cannabis Research Gap. I'm your co-host, Lakeisha Moulton.
And I'm your other co-host, Arnelle Etienne.
And in this 5-episode podcast, we'll sit down with some of the cannabis industry's leading professionals, each a subject matter expert in their own respective fields.
Over the course of this 5-episode series, we will cover topics like federal and state regulations, optimal study design, how cannabis research can translate into changes in public policy, and much more. We hope you enjoy the show. Thank you for being here with us, Dr. Mikhail Kogan.
Yeah, well, thank you. It's my pleasure being here. Love the topic you guys decided to cover, and let's talk about it.
Yes.
Get this work somehow. There we go. Let me preface a couple of things. So I, in my current role as Chief Medical Officer at George Washington University Center for Integrative Medicine, back when DC approved cannabis, I started having a lot of patients ask me questions. So this is before anyone in this area was really talking to patients about this topic. And so I kind of, just by the nature of what I do, I got pushed into this. And for full disclosure, I grew up in a culture that has a zero tolerance. If you get arrested, you get minimum 10 years in prison instantly for any possession. So for me, this whole topic was criminal, period. No, nothing medical, nothing, period. Like, you just don't touch this. So I find it's very ironic that I'm now such a strong advocate for medical use, and even to some recreational aspects, which we should discuss in a safe. There are really effective recreational ways of using cannabis in a safe way. So, and by now I probably worked with probably close to 5,000 patients recommending cannabis, and now we have several coaches in our practice that work closely with patients, just because the program grew quite a bit. So with that, let's dive in. I guess we have a lot to talk about.
The topic that we're exploring with this project is uncovering what is the current state of cannabis research, and also just dreaming into the future and thinking about what can it look like. And I think you're a great example of really understanding the ins and outs of the current regulatory situation and pathway, and using that to your advantage to be able to help serve your patients. So we have a few questions for you today. The first question I wanted to know is, can you share your thoughts on how the current schedule of cannabis affects the public's ability to access it and clinicians' ability to study it and prescribe it?
Right. So the current regulatory structure is basically says cannabis cannot be used for anything except the research. So it's a Schedule 1 DEA scheduling system, which basically says that there is no medical application, and the drug that is in that schedule is highly addictive and has a profound medical dangers, or profound danger to the organism, to the humans, which none of this, of course, is true. Cannabis has substantial medical potential. It's not very addictive. It's about 10%. It's basically less addictive than your coffee cup you had this morning, and is definitely has a safety profile that we're aware. It's not without side effects. So, having that schedule not only completely prohibits clinicians prescribing it, so you can only recommend it within the structure of a state legalization, which we'll talk in a second. And it makes public basically circumvene federal law. So if you're buying any cannabis in any legal form, while you may be buying it legally in a given state federally, you're committing a crime. And of course, nobody getting persecuted for it nowadays, because the law, there has been an addendum to the law specifically to the cannabis, that the state laws regarding medical applications should sort of trump the federal. However, there are a lot of incidents where, for example, if you cross state line with cannabis, you're seriously violating federal statutes, and you can get arrested, even though it's not happening, but it still creates this kind of a tension. So And in terms of research, everybody keeps saying, oh, okay, well, it's great. I mean, you actually can research it. Yes, you can. There are mechanisms. You can obtain research approved products. There has been recent significant improvement in the access to research grade. The problem is not that. The problem is that despite that, you still cannot obtain any federal dollars for the research. So you can only go ahead and get money from private foundations or some donors, or you can study side effects if you want to apply to the National Institute for Drug Abuse, or if you want to go to NIH, you can only study side effects or basic research, like a bench research. So nothing actually on humans. So that obviously is a big hurdle. And the last point is, which I think I'm going to put this in the context of justice, I think more than anything, because this system federally allows people to get persecuted even for illegal obtaining cannabis, by the way, forget the illegal growth and black market, I'm not even discussing that. But on the federal level, there's still tremendous injustice because there are areas where arrests are still occurring, and they're following a pretty much clear segregation across the income and racial disparities. And and this is 2025 when everybody knows that cannabis has a lot of medical potential. So it's kind of we're in a very interesting political environment that the whole country knows that cannabis is medical in most of the states, and yet feds have not moved, even though they've tried. There's been an aggressive attempt, which we'll talk about in a second, to push cannabis from Schedule 1 to Schedule 3. Which I know is your next question.
Yeah, I was gonna say, with that being said, what do you think that shift to Schedule 3, how would that affect the ability to complete cannabis research and to help prescribe it to patients?
So, I mean, the states will have a bit more capacity to create a bit more legalized process. Doctors would be able to actually physically prescribe it, because right now with the Schedule 1, you can't prescribe it. You when people go to a doctor, they get a recommendation to get a card, and then it's off the hands of a physician. Then you go to dispensary and buy products based on whatever dispensary personnel tells you, which is highly variable. Some dispensaries are amazing, and some staffed with teenagers. I mean, nothing, you guys probably teenagers, so nothing necessarily, no, just kidding. I'm not trying, but I'm saying by quite unexperienced and really not appropriately trained staff. So it's not uniform across the country that dispensaries are good. So Schedule 3 will allow to improve that. Schedule 3 will not do certain critical aspects. Schedule 3 will actually not remove some of the legal problems. For example, if you still cannot travel with the cannabis, because there's a pretty clear statements that even controlled substances, there's a lot of regulation on how you can travel with them. Number two, it seems like, okay, well, it's going to be better for research. Well, not necessarily. Controlled substance research is still quite challenging. The only benefit for the researchers that is going to change is that there will be an allowance for federal dollars to go into the looking for the actual treatment for the benefits, not just for side effects. And so we're not really sure, even from practical perspective, whether that's good or bad. So let me give you an example. Right now, I write a card. Patient either sees my coach, one of our coaches, or goes to dispensary if they're quite familiar with, products and just buy something. If it becomes a Schedule 3, it will have to be distributed through pharmacies by law, because any Schedule 2, 3, 4, or any schedule except for 1, the distribution must occur through the pharmacies. We don't actually know what that's going to look like. Example, let's say that particular state says, pharmacies will say, we don't want this. We're not dealing with this. So now what? Now the state will have to come up with an alternative way of setting up dispensaries that will have a pharmaceutical license. How is this going to be achieved? Nobody knows. Will this be, restricted highly because they will remove a bunch of products and will only pick some menu? Who knows what that menu is? So there's a lot of uncertainties here. There's a lot of speculations. There's also a really serious danger that, of course, if this happens, we will see a dramatic decrease in use of medical cannabis towards more of a pharmaceutical grade. There's going to be more of an attempt to FDA approve some cannabis extracts as an isolate. So instead of doing a whole cannabis extract, there will be an isolated to particular cannabinoid, like let's say THC or CBD, and then sold as a drug that is FDA approved. So there's a risk of that, because we know that no matter how good that's done, that will never be as good as a full extract, and there's no point in studying this any further. Of course, pharma is a pharma. They're going to try to do certain things because, it's a money-driven field exclusively, and they're going to state that their drugs are FDA approved, that they're better quality, that they're more consistent, which is, by the way, all true. However, for the medical reasoning, none of this is relevant. Quality, it doesn't necessarily mean that the efficacy. We know this really, really well. We know that, for example, for seizures, if you're buying an Epidiolex and if you're using, which is FDA approved CBD, you would need to take hundreds and hundreds of milligrams, probably thousands of milligrams to control the seizures, while if you get a full extract, the dosing will be dramatically lower, making it less expensive, making it less side effect prone, etc. So, they're not going to, Schedule 3 is not going to solve a lot of issues. It will simplify certain things. I think it will make access better, but it will create new challenges, which we don't exactly know how they're going to get around those challenges. And theoretically, it's not even going to decrease amount of arrests and amount of criminal potential. So it's a good first step towards the right direction, unfortunately, in my personal opinion, as well as an opinion in our organization, which I can disclose since I'm a board member, Doctors for Drug Regulation, which is a really solid organization, and we can discuss them a little bit later. In our opinion, the cannabis should be really completely descheduled, just like alcohol, with certain safety guidelines placed in there. And that would not only be fair to everybody, but I think it will also allow access to be unhindered, and more importantly, to be really at much lower price. So my personal main concern with moving to schedule, it's not even the legalities of technicalities, it's the cost for it. There's a reason why we call cannabis weed, right? It grows as such. And so we should be allowed, all of our patients who don't want to spend a lot of money on it, to grow it in their backyards.
Yeah.
We do know that it's very easy to grow. We do know that if you're not trying to do some really fancy schmancy, complicated strain or the variant, we don't use the word strain, the variant, simple products can be grown in anybody's backyard. Most of the states already legalized growth. So both recreational, like in state of Maryland, where we are today, you guys physically in Maryland, I presume. So you can grow up to 4 plants per household recreation. So forget the medical aspect. I'm just talking about recreation. Medical, I actually don't know if you can grow more or less. I don't remember that. But so we can save guideline this well and allow public to grow, which will keep prices down. It will allow people to actually pay almost close to nothing, right? I mean, it was just like you gardening. Why wouldn't you be able to garden the cannabis for your own purposes? And, the other huge reason why I'm a big proponent of growth is because I believe that the plant itself has profound value beyond just getting high. We're talking about flavonoids, we're talking about terpenes, we're talking about making different teas and tinctures and topical products and baking goods out of the whole plant. So we're not discussing here sort of making this advanced complex products that you go to dispenser and you have hundreds of gummies and chocolates and what. No, I'm talking about the very traditional old way of using it, just like you would you will harvest spinach out of your backyard. Why can't we do the same with weed? And again, it's going to grow as such. It's also really important ecologically because cannabis grows very easily with very little fertilizer needed. In a full sun, it will produce a pretty high amount of biomass. And so practically speaking, it's a wonderful product to also for ecological purposes. And like we drink tea from cannabis we grow in our own property in Maryland. and kids not going to get high out of that. They're getting used to these products. My own kids know what to do and what not to do, and they're comfortable knowing how to use it appropriately and not to be afraid of it. I mean, I think that's the whole point. But nobody advocates for it. And Schedule 3 will not change that. In fact, Schedule 3 may make it much more complicated because suddenly it becomes a pharmaceutical drug. It's not a drug, pharmaceutical botanical, and they may prohibit the self-growth. So we don't know how that will play out. Hopefully it will play out just, meaning they will say, okay, we'll make an exemption. Anybody who wants to grow. Will that happen? Time will show.
Yeah. And I think especially with this shifting landscape with the new administration, we really don't know what
Yeah.
direction this will take and what the priority is.
Except
Um,
that Kennedy is a huge proponent. So I think the fact that he just got yesterday confirmed for HHS, I actually think that we will see something. We're also talking in a situation where just I think last week, there was basically the hearing about moving the cannabis to Schedule 3 stop. It just dismantled it for, whatever the reasons were. I'm not, I'm actually wasn't involved in that closely. I've been busy with certain things at work. So I just know that unfortunately that whole process stalled. But it doesn't mean, and maybe that's for the best. That's what I'm trying to say.
I was
Maybe
wondering because I mean, with that push was to push it to Schedule 3, and it was like that was the only thing that they would
correct.
hear because of how the legal process works. And I think a lot of people kind of made concessions and were pushing for it because we were like, well, this is the pathway to go, but maybe there is an opportunity for
So there
advocates.
may be an opportunity. Of course, DA and FDA will be highly adamantly against descheduling, but in this atmosphere and with the new head of HHS, we may actually see a shift. We may see a shift towards complete descheduling, which I would think would be a huge service to the public. Again, I'm not saying that this should be done willy-nilly. I think it has to be done in a very controlled and careful process. But if people can drink alcohol after age of 21 and kill themselves in 24 hours with excessive alcohol, they won't kill themselves with excessive cannabis. It's not physically possible. You can't
Yeah.
consume enough to die from it. It's physically just not probable. You'll just metabolize it and you'll sleep it off. So the point being is, I think we'll have to see where that goes.
Related to that thought, as people advocate for cannabis in the legal space, what ideas should they keep in mind in terms of research? What things do you think that they should be pushing for from their state representatives, from federal representatives? What should they be asking?
We have to study the benefits. We have to push for the clinical trials. We have to push for a lot of observational trials where people just simply go to dispensary, buy what's available on the market, and just use it. And there is an observation of that. Even though it's a grade down in terms of quality of research. Of course, we want to have randomized controlled trials. But in current environment, if you go to your state politician, they're going to say, well, my hands are tied. We can't get federal grants for this. We can't get enough dollars from state budget, even though they're allowed to, but there's no mechanism for that, right? Because you also need to have researchers who are open to work with Schedule 1, which is, by the way, another hurdle I forgot to mention. The special license, it's a very complicated process. You have to have a special safe for storage, and nothing is easy with Schedule 1. So I think we need to push simply for more data gathering, and there's a lot of market interest. I actually last week met with a company in Florida that, in addition to having their own growth and dispensaries, they actually create a fascinating quality app. So app tracks every user puts in what they use it for, user puts in whether they like it or not and what the symptoms they feel like it's affecting. And so things like this are critical because that's how we will gather the data, and while it's still, we can't do all this high-end studies, it's still important to collect the data. And I think since we have, I don't know, and by some estimates, we probably have 50, 60, if not more million Americans using this. This is not cheap change, right? It's one of the most commonly used substance in the country. Why are we not understanding what people are saying? We know there are benefits, but what specific benefits? Are those benefits particularly concentrated in certain types of products or in certain types of routes, right? I can sit here and discuss my whole book that's written on this and tell you what I think, but we need to hear what people are communicating, right? We need to gather the data. And in a lack of infrastructure for the research, any data is a data. That's actually why I'm really upset with a lot of my colleagues and with the NIH and with other institutions. Some of them are very esteemed institutions, even my own institution, where I am at GW, is because there's a sort of a sense of, oh, we can't really study quality, so let's do nothing. That's just not how the science operates. The data is a data, and you can move from the gathering of lower quality data to the higher at some later point. But whatever you have in the moment is critical to communicate to general public. That's the only way we're gonna understand the field better. We're gonna have enough data, and more importantly, we're simply going to be able to communicate something effectively. Right now, critics are saying there's no data. It's all bullshit. Nothing works. Well, of course, it's not true. There's plenty of data, but you have to figure out how to look at the data, and you have to keep continuing improving this data, right? Once you found one particular, you answered one particular question, you move to the next question. Now you figured out, let's say that we can do certain types of, like CBG is good for this neuropathic pain. Well, what exactly the dose should it be? And should you take it at night or in the morning, or should you take it 3 times a day? All these questions, until you work through them, it's just like any other research question in the medical field. It's an empiric data, and you continuously improve it as you grow with the process. And we're not enhancing this. So I hope that anybody who's listening to this, especially if you have access to politicians, you go and communicate, and I think education of politicians right now, in my opinion, is most important. Public right now is more educated than most of the physicians. Physicians are usually completely clueless, or they have very wrong opinions, or they just have opinions which have nothing to do with the reality. That's the worst, I think, the last one. But the politicians are open. The problem is that they don't have any time or capacity to learn this well. So they either hearing something from industry, which, industry is industry. I love them, some players, and I don't love some others, and everywhere in between, right? I mean, it's a money-making industry, so we have to be careful. We need to rely on a bit more trusted sources of information, but politicians are really not pushing the envelope. And I feel that this is very shameful. I actually think, since we know cannabis is probably #1 exit strategy from opioid crisis, I find it criminal. I find it criminal that the whole country is ignoring this. That basically politicians are not, they're talking about Narcan as if it's a panacea. Narcan will do nothing to someone's long-term problem. It'll just save a life, but it's not actually going to save life every time. Eventually, somebody who's addicted will die, Narcan or no Narcan. You need to have a pathways to health. And the cannabis here is a clear pathway to health. We know that 40 to 50% of patients who start taking cannabis will get off of opioids. We know mortality goes down 25% in year 1, and I can give you references. This is very old data. We're talking about at least 10-year-old data in the high quality randomized controlled trials published in JAMA, published in New England Journal of Medicine. We're not talking about some obscure information. This is a standard, well available, highly referenced data. Why is this not politically discussed? So, I'm frustrated with that. And this was one of the big reasons why I decided to write the book. I said, come on, we have to share trusted sources of information and not rely on some critical voices that are clueless, pretty much.
Exactly. And I share that frustration. And I think one thing that we learned about in school that completely just ruined my day was the LaGuardia report and the Schaefer report, and how there have been reports done and that people know about and that the government knows about, that speak to the medicinal use and the lower risks. And so it really is a shame that it's being ignored. But I think like you said, the
I
more
mean, you mentioned those sources. Well, what about NAS, 2017, National Academies of Sciences? I mean, it doesn't get any more solid than that. And NAS put use of cannabis for chronic pain as grade A. You know what that means? Grade A means it's the first line of treatment, right? And that nobody, like, critics would say, it's NAS, or they will just say, no, I don't want to talk about it, or whatever. It's NAS, all right? It's the most trusted, independent, non-government organization in the United States of America, with every government organizations want to figure out how to sponsor their reports. And, and ignoring that continuously, you could arguably talk about lots of other data in different ways, but nobody can ignore NAS, right? You just can't. It's one of the most solid scientific organization, and they were not shy. They were very clear. Here is the data. Here's grade A: nausea, vomiting, chemotherapy, spasticity for multiple sclerosis, and chronic pain of any kind. Not cancer or no cancer. And that's 2017, you guys. That's actually was early in 2017. We're looking 8 years ago. Nothing changed politically. Nothing.
What unique challenges and advantages exist when studying cannabis in the geriatric population?
So that's my main expertise. I think more than half of all the recommendations I've ever made and worked with patients were in that population. So, I mean, and the reason I'm so vocal, and actually originally I wanted to make this book specifically for geriatric population. It's just a random house said, no, we want for everybody. Geriatric is too small. And the reason is very simple. So, when people get older, they end up on multiple medications. So there's a statistics that by age of 65, about half of all the US population takes at least 3 or 4 medications. And we know that, about 250,000 deaths per year from drugs that we prescribe, from appropriately prescribed medications, are primarily in that population. And so, we know that the drugs we give, particularly for pain, they're not effective. There's no effective treatment for chronic pain. Opioids, Tylenol, Motrin, NSAIDs, whatever. All these drugs have tremendous amount of limitations, but the bigger problems, they tend to have a lot of side effects. They kill millions and millions of people every year. The problem, not millions, thousands and thousands of people every year. The problem is that, we don't do any better. And so when I started using cannabis in my practice, I started realizing how powerful of an exit drug it is in certain situations, in certain settings, when it's done right, and completely safe. And by the way, we talk about side effects of drugs, but cannabis have side benefits. People start getting less depressed and they sleep better and they have better mood overall and they have more energy because they sleep better. So suddenly, you have this other areas affected. And I often joke, especially in palliative care, so towards the last 6 months of life, I can give people 5, 6 drugs to control other symptoms, or I can just give one cannabis. And guess what? In addition to that, people get euphoric. In studies, they record euphoria as a side effect. I'm yet to see a single dying patient who would claim that euphoria is a side effect. So this is an issue. We have a product that in patients who are frail, who are in their last decade of life, seems to be not only safer, but has a tremendous potential for improving quality of life. And this is why I jumped on this. And, I think particularly nowadays, we're looking more and more into non-intoxicating cannabinoids. So for non-THC things, like particularly my most recent research is around CBG and CBDA. I don't think we have time to go into nitty-gritty details of this, but for example, I will tell you that CBG seems to have a really effective chronic pain control, chronic neuropathic pain control at the fraction of the cost of CBD, because your dose that is needed is much lower. So combining a low doses of THC with some of this other cannabinoids is where I think we're currently learning tremendous amount of information and shifting a lot of patients from kind of a more dangerous drugs, just like what you said, it's an exit strategy for so many chronic severe symptoms, and I'm not just talking about pain. I'm talking about a lot of abdominal symptoms, nausea, vomiting, constipation, diarrhea. I'm talking about a lot of sleep disturbances, chronic insomnia, all kinds of sleep disturbances. I'm talking about anxiety. I'm talking about depression. I'm even talking about severe problems like Alzheimer's disease, right? We know that patients with advanced Alzheimer's will always end up with some kind of either poor sleep or agitation or paranoia or behavioral problems, so all kinds of issues. All of that can be quite effectively managed with cannabinoids, but you have to know what you're doing. It may not be a high amount of THC. You may need to rely more on a non-intoxicating cannabinoids like CBD, for example. So, it's a fascinating topic. I hope, again, why I'm pushing towards complete descheduling, again, because I do think that even the hemp industry, so purely non-THC based industry, has a big role to play if it's done with a good amount of evidence and good research.
Thank you for that. And I'm excited to hear more about the clinical perspectives. And I think that the geriatric population is such a, first of all, beloved for me, population. And so I love that they have something to improve their quality of life. So yeah, thank you so much.
Well, everyone, that concludes our show for today. We hope you've enjoyed the content. I'm your co host, Lakeisha Moten, and we will see you guys next time. Feel free to check out the show notes and the resource links.